Good afternoon and good morning to many of you, and welcome to day 2 of the 2021 reverse site visit. For those of you I don't know, I'm Terry Hill. I'm the Senior Advisor for Rural Health Leadership and Policy at the National Rural Health Resource Center. I hope you all had a good evening, and I'm excited about the agenda for today. As we begin, I have a few announcements. First of all of the sessions are being recorded. Second, if you should run into technical difficulties, on the right side of the screen, there's a phone number and an email address you can use to help with the situation. And you may want to write down for future reference 877-563-0031. Participant microphones in the plenary sessions are muted. We do, however, encourage your questions and interaction with the speakers. And if you have any questions during this session, you can utilize the chat box feature with the media player. The task team will be monitoring the presentation, either answering your questions or communicating them to the speaker. So each year at this event, we give out the Calico Leadership Award. This year, I thought it'd be important to talk to you a little bit about the background as to why that award is presented and who Dr. Calico was. Dr. Calico was really our first Flex program officer, and I want to tell you a little bit about him. First of all, he was born in rural Kentucky into a farming family. And he died about 5 years ago at his family farm, where he had retired from the Federal Office of Rural Health Policy. And one of my favorite pictures is of Dr. Calico on his tractor in the last few years of his life. During his long career, he was a family physician, a flight surgeon in the Air Force, a family practice residency director, a hospital administrator, the president and CEO of Appalachian Regional Healthcare, and the University of Kentucky honored him into their Public Health Hall of Fame. Just an incredible person. During all those years, I rarely ever heard Dr. Calico talk about himself or about any of his accomplishments. He was an extremely kind, encouraging man, and he was very supportive of both the state flex programs and TASK. You know, in the early days of TASK, was kind of like some of you who are new to this program. We didn't know entirely what we were doing, and so we had to forge that program, and Dr. Calico was just such an extraordinary supporter during that time. And that leads me to the introduction of Tom Morris, who's going to be presenting the Calico Award this year. And I know yesterday our keynote speaker talked about the acknowledgements for the state flex programs and also for our Rural Health Resource Center. But I want to continue those acknowledgements today with the Federal Office of Rural Health Policy. We have worked under contract with the federal office for the past 26 years. And, just basically starting with Jeff Heumann, I think, who was the very first leader of FORHP, Jerry Coopy, Dr. Calico, Marcia Brand, Wayne Myers, et cetera. We've just had terrific leadership from the federal office, and we've had terrific staff as well. So I know, folks at the federal level don't often get acknowledged, but I just want to say that we're extremely appreciative of that. We're appreciated at the center, but we should all be appreciative of the important role they play on behalf of rural America. So Tom Morris has continued that kind of terrific trend of leadership at the center. He's an associate administrator of rural health policy at HRSA. He oversees an annual budget of $317 million Back in the 1990s, when we first went under contract with the federal office, I think they had 3 or 4 staff total. So that program has grown exponentially almost. Tom's a North Carolina native who came into government as a presidential management intern. And in 2015, he received the Presidential Rank Award. So with that, I'm going to turn it over to Tom to present this year's Calico Leadership Award. Tom?
Great. Terry, thank you so much for all that. And it's great to hear all those names and remember all the folks who sort of set the foundation for us in this work. I appreciate you providing everybody with that context. And thanks for the opportunity to join you and present the Calico Award. I think I'd like to make a couple of comments just before we get to that, just to really credit you all for the theme for this year's meeting. I think the notion of resiliency has never been more important than it is now, and I trust everything went well yesterday, and we're looking forward to a good day today. And I just really want to thank all the FLEX program partners, all the state offices of rural health, all the staff that work on this, all the task staff for their support on this. We've really been on a journey with the FLEX program over the years, and I think the support as we've moved into the Medicare Beneficiary Quality Improvement Program has been really great. And we're in a position now, I think, where we can really make a link between the FLEX funding and showing actual quality improvement at the participating hospital level. And we can do the same on finance. And we've also made really great strides, I think, in the area of EMS. And that doesn't happen, by accident. That happens because everybody buys into a vision for what the program is. And it really is a partnership. I mean, we provide the funding to the states, but the states are the ones that do the heavy lifting of convincing the hospitals to take part in this, showing them that there's value in working on these activities. And then that way, we can show that we're having an impact nationally as a result of all this. And I appreciate you bringing up the staff, because I do think that they deserve a lot of attention for what they've done. So I'd like to just mention a couple of them if I could. Tori Leach for her leadership on the FLEX program. She's just started on that, but she's really done a great job with it. And in fact, she's broadening even beyond that. She's sort of leading our efforts to think through what this new rural emergency hospital model is going to be, and working directly with the folks over at CMS. Natalia has been a leader for us, Natalia Vargas, in terms of thinking about our quality improvement efforts and our collaboration on the Arquita contract. And then Laura has done a great job in terms of leading the financial and operational and the links to the FLEX monitoring team. And so we appreciate that. And then Talia Chappell has joined us and done a really nice job in terms of integrating our work around EMS. And so, I think it always takes a group of folks to run a program, and it takes grantees who are willing to support those efforts. And I think we have a really good partnership here. I think a good example of that is the quality innovation labs that are underway right now. I think that's a really important step in sort of creating the opportunities for folks to learn from each other, and a great way for the hospitals at the state level to think about the quality metrics. But, I think it's also more than just quality. I think that we've got a really good way now with the data that's coming in to show a direct association between, if you get a hospital involved in FLEX activities, they're going to see their quality improve and they're going to see their finances improve. And that's a really, really powerful argument. And it's been many, many years in the making, but I just want to thank everybody for getting us to this position. But with that, let's talk about the Calico Award, because I think you said it really well. FORHP was a real leader in this effort. When the FLEX program was first starting, we were focused very much on just the conversion of hospitals to CAHs. And, that's a pretty straightforward activity, but we realized it needed to mature. And FORHP had a real vision for this program as being a national leader in making sure that rural CAHs were not left behind in the broader national effort around quality improvement. And it was right around the time the Institute of Medicine to Era's human reports started coming out, and there was a real focus on improving quality. And he saw the FLEX funding as an opportunity to really do that at the local rural community level. And so, we loved working with FORHP. I learned a lot from him. I probably should have been working for him rather than the other way around. But he really shaped the program into what it is today. And Christy Martinson's done a great job in sort of taking over the leadership of that, but Forrest really set the foundation, and we're really appreciative that you all have created this award, and then it goes out each year to somebody in the Flex family. And so I'm really pleased to announce that this year's winner of the Calico Award is Peggy Wheeler from the California Hospital Association. She's a longtime champion of rural health. She's led their rural healthcare center. And prior to that, she was a health policy analyst with the California Legislative Rural Caucus. Peggy holds a master's degree in program and clinic administration from UC Berkeley. I've known Peggy for a number of years, and we were lucky to have her on the HHS National Advisory Committee on Rural Health and Human Services. And I think in the 30 years we've had that committee, I don't know that we've ever had a stronger advocate for rural. She had a great way, on this committee, which is very diverse, has human service people and health people, and typically there's 2 or 3 hospital people on it, but there's a lot of folks from very diverse backgrounds, and she could explain these very complex topics to them in a way that was meaningful. But she also did a great job of saying, okay, let's stop talking and let's get to action. And it was a great benefit to us to have her on the committee, and so I can't imagine anybody more fitting for this award. And just thank you, Peggy, for all you've done and for the chance to work with you. And with that, I'm going to put you on the spot.
Oh, my gosh. Okay, so nobody does this to me anymore. There are no surprises in my life. And you guys have just overwhelmed me. I can't believe it. Wow. So I don't have to talk about anything else? Oh, my God. Oh, I cannot tell you how much I appreciate. And from you, Tom, it just means the world to me. Tom and John and Brock and Sally, all of you, Terry, just such good friends. You know, the thing is, I was listening very closely to your commendation for putting together a program called Rural and Resilience. And I was thinking to myself that it's synonymous. You guys used words that mean the same thing, because to be rural is to be resilient. I've been doing this for a long time, and my passion work is rural. And to be honored in such a way today by surprise means the world to me. And Ron, I'm going to pay you back for this. Thank you very much for the honor. It means the world. It means the world. Thank you.
All right. Well, with that, I think we go back to Terry. So.
Yes, and I just want to add my personal congratulations to that, Peggy. It's so richly deserved. So, and she's done a ton for TASC as well, and just an extraordinary leader. I'm going to introduce another extraordinary leader, our CEO of the center, Sally Buck, who is in turn going to introduce our panel.
Yes, there we go.
Oh, good.
Goodness. Well, thank you, Terry, and congratulations, Peggy. So well deserved, and such an honor to have you among the Calico Award recipients. Next up, our plenary session is Rural Health Policy and Regulatory Updates. Today's learning objectives, I'll repeat them one more time for everyone, to identify opportunities and mitigate challenges for rural safety net providers in the current state of healthcare policy and regulations with the ever-changing environment. Our panelists include Brock Slobach. Brock joined the National Rural Health Association, NRHA, in 2008. He was a rural hospital administrator for more than 21 years. As Senior Vice President for Member Services, Brock specializes in rural system development that encompasses population health and the varied payment programs, moving rural providers into value-based purchasing models. Brock is a 2015 recipient of the Calico Quality Leadership Board and a fellow of the American College of Healthcare Executives. Our next panelist is John Supplitt. John is the Senior Director of Rural Health Services for the American Hospital Association. Since 1993, he has worked with and on behalf of AHA's 1,800 rural hospital members, including 975 critical access hospitals, to identify, develop, and enhance their unique healthcare interests, issues, and perspectives. John manages the Member Services, Leadership Council, and Communications, and he's served on several national panels and advisory groups, including TASK, for development of rural health policy, program development, and demonstrations. And John also is a recipient of the Calico Award. And next up, we have Sarah Heppner. Sarah is the Director of Policy Research Division, or PRD, in the Federal Office of Rural Health Policy. She's been with FORHP since 2012, and prior to becoming the PRD Director, she served as a research coordinator and then as Deputy Director of FORHP's Office for the Advancement of Telehealth. Her professional interests include health services research to understand the impact of policies on access to care in rural communities and rural health disparities. And we have a series of questions that I'll pose to our panelists, and we also encourage questions. You can put those in the Q&A on the little icon to the right of your hub screen, and then they'll feed those into me, and we'll take questions towards the end of the discussion. So our first question, what are the current legislative issues your organization is pursuing to support critical access hospitals? And we'll start with Brock on this question.
Well, thank you, Sally, and it is a pleasure to be here with you at the reverse site visit, and I'm excited to be able to share in this presentation. I'm also excited to congratulate Peggy on her well-deserved honor for the Calico Leadership Award. She is truly deserving of that, and I'm excited, having known Calico Forest myself, to see her get that. To answer your question, Sally, there's a lot legislatively going on right now as we move through the pandemic and see the effects of what that has had on rural communities. Our primary interest at the moment is looking at the American Rescue Plan and then the associated American Family Plan. That seems to be front and center, at least in the attention of Congress right now. What we know of the American Rescue Plan is what's also styled as infrastructure. We've had infrastructure weeks now since the Trump administration moving forward to this current time. And our main priority within that infrastructure bill is to make sure that we improve broadband and telehealth services in rural America. We invest in rural workforce, including healthcare, and then capital funding for rural hospitals to build and enhance their infrastructure for the future. We're seeing some resistance at this point in terms of our ability to get healthcare added as a feature in the infrastructure bill beyond just roads, bridges, and transportation. Other areas that we're pursuing within the American Rescue Plan is rural housing investments, community college, and other post-secondary investments in rural. So that's a big order. Then you have the other plan, which is the American Families Plan, which they're calling, I think, in a way, the soft side of infrastructure. And that's things that I think that are very important for rural communities, particularly looking at things like childcare, elderly care, taking care of parents that are aging. These are those soft investments that really could unleash the power of the economy to be able to thrive, because people can return to the workforce without having to worry about children and elder care issues. Then we move into the area of our appropriations. So we're in appropriation seasons now as we move into the summer. And the House Appropriations Committee has held some committee markups featuring agriculture, rural development, Food and Drug Administration, and related agencies. NRHA is really involved in a couple of areas of rural development of appropriations. The first is we want to establish an Office of Rural Health within the Centers for Disease Control. We're making some really good progress on this. We have Senator Hyde Smith from Mississippi, a Republican from that state, that has signed on, for example, to that piece of this appropriation request. Expand the USDA Rural Hospital Technical Assistance Program. RMOMS, the Rural Maternity Obstetrics Management Program, we want to see expanded. Rural Residency Planning and Development, the Office of Advancement of Telehealth. And last but not least, very important to the folks on this call, is the reauthorization and modernization of the Medicare Rural Hospital Flexibility Program. So we're actively trying to make sure that those elements are included in the request that's going to Congress. And then very quickly, we have a whole host of advocacy agenda items for legislation that include rural emergency hospital designation, and that's already been passed as part of the Consolidated Appropriations Act. But we want to make sure that going forward, if we need legislation to improve that through technical corrections, that we are in place to do that. We're very interested in seeing the reinstatement of necessary provider program for for PPS hospitals to convert to CAHs, and then the elimination of the 96-hour rule for critical access hospitals. That's that condition of payment that requires a certification that the patient will not stay longer than 4 days. So we want to see that removed. Graduate medical education through the Rural Physician Workforce Production Act, we're very active in pursuing. Telehealth flexibilities, those are going to be ending with the public health emergency. I already talked about rural maternal mortality and morbidity, behavioral and health and substance use disorder assistance, and then rural health clinic modernization. And I'll close with this. We are extremely interested in pursuing the creation of some way to let provider-based rural health clinics get exception to the upper payment limits that were provided through the Consolidated Appropriations Act. And we propose to do that through exchange for requiring quality reporting for rural health clinics in exchange for that increased reimbursement. So those are some of the things that we're pursuing legislatively. And I'll stop there and turn it back over to you, Sally.
Thank you, Brock, for sharing. It's a very busy time in legislative issues. And John, from the American Hospital Association, what are you pursuing? And John, you're muted, John.
Thanks very much, Sally. And I'd also like to add my congratulations to Peggy, who's a very deserving recipient of the Forrest Calico Award. I'm really going to validate much of what Brock just shared. I'll add a little detail in some of those areas and those issues as well. But like NRHA, we're really concentrating our efforts on infrastructure. And when we look at the federal investment that's necessary to ensure that our rural communities are able to preserve access to essential health services, we're focusing on the key areas of investment that include physical infrastructure and right sizing, the capacity to enable digital health, workforce support, and then access to behavioral health services. And when we reference physical infrastructure upgrades and right sizing, we're looking at funding to maintain and update the transformation of physical plants so they can better serve the future and current needs of the communities we serve. We want to be able to allow hospitals the opportunity to convert to newly created rural emergency hospital provider types, or strategically shift towards focus on outpatient services or facility renovations or whatever improvements are necessary to restructure how and where they serve and offer services. With respect to right size, we understand that as we look forward, they're going to have to reconfigure services beyond the four walls, particularly as we look more towards telehealth and outpatient and post-acute care services. And many rural hospitals are shut out of traditional capital markets. And like Brock was saying, access to capital is an important part of any infrastructure program that we want to see coming from the Biden administration and Congress. Regarding access to broadband, again, it's essential to reducing health disparities by connecting patients to rural and underserved areas with a full spectrum of caregivers, including behavioral health providers, and significant additional investments necessary in order to offset the high upfront costs of construction and any last mile broadband connectivity. Regarding building telehealth capacity, we want to offset the infrastructure costs related to telecommunication services, information services, and devices to provide telehealth to patients at their homes or locations, especially those patients who are unable to secure other points of access to the healthcare system. We want to eliminate geographic and setting requirements, ensure reimbursement for originating sites, allow Medicare coverage for payment for audio-only communication. We want rural health clinics and FQHCs to be allowed to serve distance site and provision of telehealth services, and the license requirements should be coordinated across state line. Regarding workforce, we want to see target programs that help address workforce shortages. We want to increase the number of residency slots. We want to fund educational loan paydowns and vouchers. We want to provide grants to expand, modernize, and support schools of medicine and schools of nursing. We want to bolster the capacity of these schools. And with respect to behavioral health, we want to be able to provide end user devices to upgrade audio video technology to support telehealth and provide for the construction of new sites of care to improve access to behavioral health services. Now, when we drill down on specific points of legislation, with respect to workforce, there's the Residence Physician Shortage Reduction Act that would add 14,000 Medicare-funded residencies. That's 2,000 positions per year over 7 years. We want to look at the the Healthcare Workforce Resilience Act, which is bipartisan legislation that would expedite the visa authorization process for nurses and physicians, as well as the Conrad 30 Physician Access Reauthorization Act. And regarding telehealth, it's Protecting Rural Telehealth Access Act that would expand the list of permissible originating sites and allowing patients to access telehealth services from their homes. And like Brock, we also would like to see a reintroduction of the necessary provider provisions to waive the 35-mile rule for designating critical access hospitals under the Medicare program, and to test and implement new models of rural payment and delivery. And also, I think it's important that we look at the Accountable Care in Rural America Act. That's bipartisan legislation that's going to revise the benchmarking formula for the Medicare Shared Savings Program to give better opportunities for rural providers to participate in ACO two-sided shared savings. And as also Brock mentioned, the Rural Moms Act, authorizing grants to implement obstetric networks, maternal telehealth programs that will provide support for entire pregnancy and postpartum periods, a maternal care demonstration for providers in rural settings, and to improve rural obstetric data collection and reporting on women's health outcomes on the basis of socioeconomic and geographic factors. Those are at the top of our legislative list right now as we move forward, and look forward to taking questions and having conversation about that later.
Thank you, John. We appreciate hearing the legislative issues being brought forward and some of the details in those specific ones for critical access hospitals. Next, we'll move to the regulatory issues, the critical access hospitals in the rural health clinic space, including incoming proposed rules or funding to be aware of. And we'll start with Sarah Heppner on this question. Sarah?
Hi, everyone. Thanks so much for inviting me to join the panel today. And of course, congratulations to Peggy on your award. So I'm going to start by talking through some of the different programs and funding opportunities that we will either have recently come out or funding that will soon to be hitting the street around this area. So starting with the ARP funding, of course, you're all aware of the SHIP funding that came out when looking at testing and mitigation, providing support to rural hospitals. We have similar funding that went out earlier in June for rural health clinics around testing and mitigation efforts in rural communities. The RHC program we affectionately call as part of our RHC trifecta. So the first program was a push payment that went out to all rural health clinics to make sure that they had the resources available to do testing, but most importantly, mitigation activities in rural communities. We also hope to be announcing any day now the awarding for the rural health clinic Clinic Vaccine Confidence Grant Program. So this was an opportunity for rural health clinics to apply for funding to be able to do work to increase vaccine confidence in their communities. And then lastly, the third part of our trifecta is our Rural Health Clinic Vaccine Distribution Program. And this is an ongoing program where folks can sign up to receive direct allocations of COVID-19 vaccines, and separate and apart from anything that you might be receiving from your state or from your jurisdiction, we can get access to any of the 3 COVID-19 vaccines. So whatever best fits your community needs, to make sure that we are not missing any opportunity to vaccinate someone who is willing and eligible to be vaccinated. And I am certainly happy to share more information about all 4 of those programs. Also on everyone's mind, of course, is the provider relief funding. HRSA has not yet issued the $8.5 billion in ARP funding targeted to rural providers. We don't have a firm timeline yet, but we anticipate that the application window will open in the next month or 2. And I do want to just pause and point out that this is going to be an application that rural facilities, rural providers will need to go through, but we'll make sure, obviously, that we're clearly communicating that to all of our rural stakeholders so that no one misses that opportunity to apply. And I also want to recognize that I know that there are concerns about how these funds can be used and any reporting requirements that might be attached to it. This is something that we have heard, loud and clear from stakeholders, but we want to make sure that we are continuing to talk to rural stakeholders, hearing your concerns, and that we're helping to find a path forward to make sure that rural providers who want to take advantage of this funding are set up for success. So we would just ask, if at all possible, keep an open mind about this and don't rule it out yet. We're still working and trying to make sure that there is a path forward where everyone can be successful on this. Of course, telehealth, as Brock and John have mentioned, is certainly something that we're keeping an eye on. As you know, the public health emergency has led to a number of flexibilities and waivers to make it easier to implement and access telehealth services. And of course, many of these flexibilities are only effective through the end of the public health emergency or until the end of the calendar year in which the public health emergency ends. For instance, the CARES Act authorized RHCs and FQHCs to be able to provide services as a distant site provider using telehealth during the public health emergency. But there's, of course, strong support from stakeholders and policymakers to make this authority permanent. Other telehealth, Medicare telehealth flexibilities that have been implemented by CMS include expanding the list of telehealth services, removing geographic barriers and the setting of care restrictions, such as allowing patients to receive telehealth services at home or allowing for audio-only visits, and expanding the type of practitioners that are eligible to provide telehealth, such as physical therapists or occupational therapists, among other changes. We also know that in order for the federal government and HRSA to expedite awareness and adoption of telehealth, these flexibilities and changes would need to be extended or made permanent. And there is movement in this direction, as CMS is proposing to permanently allow for Medicare telehealth payment for mental health services, including for audio-only communication technology. In implementing Section 123 of the CAA, the Consolidated Appropriations Act of 21, CMS is going to remove the geographic restrictions and add the home of the beneficiary as a permissible originating site for telehealth services when used for the purposes of diagnosis, evaluation, or treatment of a mental health disorder. CMS is also going to require that there be an in-person non-telehealth service with the physician or practitioner within 6 months prior to the initial telehealth service, and thereafter at intervals as specified by HHS. I think it's important to note that CMS is seeking comments by September 13th on these proposed changes through the calendar year 22 Medicare physician fee schedule rule. And it's always really important that we make sure that rural voices are included and the rural experience is included in this comment period. So I'd strongly encourage all of you to think about submitting a comment on that that reflects your experiences in rural communities. On the Medicaid side, telehealth coverage, as we all know, differs from state to state. However, most states have expanded Medicaid coverage for telehealth, with many states now allowing telehealth services via telephone, again, using the home as the originating site for telehealth, and coverage and pay parity for telehealth services. And many states are currently considering or have already made permanent the expansion of these telehealth flexibilities beyond the federal public health emergency for COVID-19. HRSA, specifically our Office for the Advancement of Telehealth, are going to continue to monitor the status of these telehealth changes and flexibilities before and after, or during and after the COVID-19 pandemic, and make sure that we are letting everyone know about these changes and also opportunities to comment, as I mentioned earlier. So thinking about grants and opportunities that are coming out of our office, the grants.gov forecast for FY22 is available. Of course, that's all dependent on what our fiscal year 22 budget looks like. But I would encourage you to check that out. I know we've talked about GME a lot already on the call. So for example, the Rural Residency Planning and Development Program is one of the grant programs that's currently on the forecast. Again, as budget depending, of course, that's always our qualifier until the budget is released for the fiscal year that we're talking about. Going back to that idea of requests for information, there's 3 RFIs that I want to make sure is on everyone's radar. The first is for the Rural Emergency Hospital. We've already talked about that a little bit on this panel. It's the first new provider type since critical access hospitals were established, and CMS is seeking information to inform the development of requirements that would apply to rural emergency hospitals, including potential services, health and safety standards, quality measures, payment provisions. And I think it's really important, again, that rural providers speak up and make sure that CMS is aware of your opinions and your thoughts about how best to implement the rural emergency hospital designation. With COVID-19, CMS is seeking comment on the extent to which hospitals are using flexibilities offered during the COVID-19 public health emergency to provide mental health services remotely, and whether CMS should consider changes to account for shifting practice patterns. And then, of course, around health equity, CMS is seeking input on ways to make the reporting of health disparities based on social risk factors and race and ethnicity more comprehensive and more actionable. And this includes soliciting comments on potential collection of data and analysis and reporting of the quality measure results by a variety of demographic points, including race, Medicare and Medicaid dual eligible status, disability status, LGBTQ plus status, and socioeconomic status. The last thing that I want to make sure that I mention is that, going back to this idea of the role that FORHP has. Obviously, our role is a little bit different than AHA and NRHA, given that we are part of the Department of Health and Human Services. And I want to make sure that you all know how important it is that we have information from you all about how the realities of various CMS payment policies are actually playing out on the ground and impacting your communities. We have really 2 main roles, and that's, to implement the programs that are assigned to our office, and to make sure that we're effectively allocating our budget dollars out to rural communities, but also to be a resource to our colleagues and a voice for rural across the Department of Health and Human Services as rural relevant programs are being developed and policies are being implemented. And we're actively working with our colleagues at CMS whenever we can, specifically around the rural emergency hospital designations and around the GME provisions that were included in the Consolidated Appropriations Act of 2021. But we really want to make sure that we are doing our due diligence and being that voice for rural, and making sure that we are taking the experiences that you all are having on the ground and lifting them up and making sure that we're accurately representing them across the Department of Health and Human Services. So please make sure that you are reaching out to us through any means possible. You can always email ruralpolicy@hrsa.gov. That's ruralpolicy@hrsa.gov, and it goes right to all of our policy analysts, and they can make sure that they are understanding and appreciating the experiences that you all are having actually on the ground and serving rural communities. So let me pause there, Sally, and turn things back over to you.
Great. Thank you, Sarah, for sharing all the updates on the issues and funding through the Federal Office of Rural Health Policy and CMS. And now I'll turn to John. Other comments on regulatory issues for critical access hospitals.
Yeah, thanks very much, Sally. And as Sarah is going through this, you can get the feel that there's a lot happening in the regulatory policy world as well. And I'm going to add some additional observations to what she's just reported. And I'm going to begin with the executive orders from the president and the administration. Two of which have captured our attention. The first of which is the Promoting Economic Competition executive order, which is expansive and establishing an all-out government effort on looking at competition in the American economy. With respect to healthcare, the executive order targets drug costs, commercial health insurance plans, and hospital and health systems. But for us, it erroneously suggests that consolidation among hospitals has led to high prices and inadequate access to health services in rural communities. What we've learned from the pandemic, if nothing else, is that you cannot go it alone. And the challenge that hospitals have had and the means in which they were resilient to transform their operations, to expand their capacity, to expand to telemedicine, to overcome shortages in equipment and drugs, to retool their operations and reconfigure space, did not happen in a vacuum. And we need the administration to acknowledge that when they're looking forward at this executive order on competition. The other executive order that's caught our attention is the OSHA COVID-19 Healthcare Emergency Temporary Standard. And as part of this executive order on protecting workforce health and safety, healthcare employers are required to take certain steps to protect workers in settings where suspected or confirmed COVID-19 cases exist. OSHA then on June 21st has released this rule, which is long and complex and would require hospitals to change policies, procedures, and structures in order to protect workers in settings where there's suspected or confirmed COVID-19 patients. What we're disappointed in is the unrealistic timeline for compliance with this executive order. While OSHA has refused our request to extend the compliance dates and has released its field inspection and enforcement procedures, they have extended the dates for comments on this executive order, and we encourage you to join us in explaining to them the damage that would be caused by this unrealistic short compliance period. With respect to other rules that are out there, I want to focus on the outpatient PPS rule, and specifically the hospital price transparency, which are included in that proposed rule, and include the definition of hospitals and standard charges, requirements for making a machine-readable file online that includes standard charges, requirements for making a public standard for shoppable services, 300 shoppable services that are displayed and packaged in a consumer-friendly manner on your websites, or the use of an online price estimator, and monitoring for hospital non-compliance and actions. We really believe that CMS has overstepped its authority in designing the transparency final rule, and we are looking to try to work with them to find a common ground on how that can be best implemented to secure the information and provide transparency in a meaningful and useful way for consumers. Also contained within the outpatient proposed rule, in which Sarah has already touched on, was the request for information for the rural emergency hospital provider type, which we're very excited to see included in this rule, and we'll be building our comments on to provide them with feedback on health and safety standards, payment policies, and quality measures for rural emergency hospitals. When we look at other rulemaking that's taken place, I have to bring up the No Surprises Act. This is an interim final rule that addresses several of the provisions in the law that includes a ban on balance bidding, notice and consent of process that some providers may use to bill patients for out-of-network services, how patient cost sharing must be calculated, and a complaint process for any potential violations. This interim final rule also contains what we believe is a very important, strong rebuke of health plan actions that deny coverage of emergency services. We're working with the departments to carefully reconsider some aspects of the rule that may inadvertently create a financial windfall for insurers or financially destabilizing providers. So that remains a priority for us as well. I think I'll pause there and turn it back to you, Sally, with respect to other rulemaking that Brock might want to address.
Okay, thank you, John. Yes, and Brock from NRHA.
Well, thank you, Sally. And John did a fantastic job of covering many of the regulations that we're dealing with, all of them. In fact, we comment in our office that we've never seen such an avalanche of regulatory activity, just one right after the other. And the other comment I'll make is they all seem to fall on Friday before a holiday. So it's Memorial Day and 4th of July, Friday afternoon at 5 o'clock. So I'm expecting Labor Day weekend, 5 o'clock. You can count on something major happening coming out that we'll spend the weekend reviewing. I do want to pick up on something that Sarah touched on, and that's the provider relief funds and the intricacies that providers, critical access hospitals are dealing with right now in terms of trying to account for those dollars. And I want to just extend a note of appreciation to HRSA and to FORHP for their willingness to sit down with NRHA. We've had a number of meetings over the last 4 or 5 weeks, trying to cover some very complicated territory regarding critical access hospital reimbursement and how that factors into the accounting periods and cost-based reimbursement within the construct of lost revenues. We also were looking at trying to figure out, what on the capital side of it for the June 30 window of time for construction or capital expenses related to the PRF. So that's something that we're still pursuing, and it's very active. I would say that 1 out of 3 or 4 of our contacts to NRHA is regarding the provider relief funds. I agree with John on everything. I mean, it's like the executive order that came out a week or 2 ago on promoting competition in the American economy, and the references in there. One to competition, mergers and acquisitions. We had a meeting with some of the researchers in the business of looking at these subjects from a scientific point of view, and we're trying to uncover some data to really dispel some of the aspersions that this executive order made. And we're focusing on the rural part of this. So anti-competitive activity in rural is really kind of an oxymoron in the sense that you have distances between providers. So that's something that we're developing and hope to be publishing more about as we move forward. The price transparency regulation, again, a huge problem. And the thing I'll note about that, John's absolutely right. The thing that's different now is the press is starting to pick up on this. So in the last week or maybe 3 weeks, I have heard 3 or 4 major news stories on various national outlets on this topic. So I would recommend that you advise your clients, your stakeholders within your Flex programs, that they need to be looking at this, because I think folks in the press are going to be making these notions more and more as we move along. And then the OSHA rule is the thing I'll comment there is that much of it is outdated. So a lot of the science that they are using in the development of this rule that OSHA put out is simply about 8 months to a year dated in terms of its applicability. So they need to get that in line with NIH, CDC, and other agencies that have put forward and CMS conditions of participation. They need to make sure that those are consistent. In the area of, I think let's see. I think that just about covers it. I'll tell you, like I said, this has been a busy time period, and I don't think John mentioned the inpatient rule, the outpatient rule. Those are coming out. The physician fee schedule rule came out, so that's something else to keep aware of, and we're issuing a statement or a letter on that. So you can go to our website at ruralhealthweb.org and get lots of good information on that. So with that, I'll turn it back over to you, Sally.
Thank you, Brock. Appreciate the perspectives on the regulations and funding from all three entities. Now we'll move into what are the operational priorities given proposed policy and new regulations for small rural hospitals and clinics that we want Flex program staff to know about that their hospitals should be focusing on. And I'll start with Brock, with you on this one.
So this is the question on value.
On the operational priorities, such as like quality star ratings and.
Got it. Yeah. So I think that if I was to look at operationally at a facility right now and give advice, I would go to the basic formula for value. And that is looking, and this is age old, it's quality plus service over cost. When I define service, I mean now patient experience and healthcare worker experience. So it's really the quadruple aim. And I would start to pick that apart because I think that, again, this public notion and the doctrine of consumerism, I think, is going to be picking up quite fast with all of the attention to it. So we're looking at quality, and when you talk about that, transparency around your quality measurement program, and that's going to be particularly relevant in star rating. So obviously being more attendant to that kind of elusive process that many of us don't understand and becoming more aware of its impact, because the consumer is going to be looking at that, or maybe more appropriately, the insurance companies are going to be looking at that more intently. Patient experience and staff experience. Those are two really important things when you look at staff experience, your workforce of your healthcare workforce, making sure that they're well kept and being able to provide the care that they need at the bedside. And then, of course, patient experience. We've been measuring that for a long time. Cost is the other area, and you all we've talked about this already with transparency. This is going to become more public and more competitive as you go forward. I think that these price transparency regulations are going to move us to basically to a single pricing standard, which is going to be a pricing floor. And I don't see any movement in that going forward. So I think that budgets are going to have to reflect that reality going forward, and understanding that this is going to be a pressure that we haven't seen really intensely before. And I look at the insurance company, by the way, now as the surrogate for the consumer. So the insurance company is essentially buying care on behalf of the people that they insure. And I've heard a lot of my hospital colleagues tell me that the only folks that have been traveling to their transparency sites on their websites is insurance companies and competitors. And I thought through that, and I thought, well, I guess that really makes sense, because the insurance company is really buying care on behalf of the consumer. And so I don't see any change in that going forward. And I think that's a really important question to deal with there. So then I'm going to close, and we'll talk a little bit about this with in another part. But I think innovation, and we're going to have to take advantage of all the grant programs and money that's coming down the pike through CMMI and other innovation networks to be able to transform really the way we deliver care. And we can talk more a little bit about that later. I do want to put a plug while I'm thinking about it and let you know, as a matter of news, Liz Fowler, the director of the Centers for Medicare and Medicaid Innovation, has been confirmed as a keynote speaker at our Rural Health Clinic and Critical Access Hospital meeting in September. So you can go to ruralhealthweb.org and check that out. We are excited to have Ms. Fowler as a guest at that meeting to hear what CMMI's vision is for rural, in the innovation space, and that's the challenge that I'll be giving to her in that session that she'll be conducting. Sally.
Great, thank you. Okay. And now we'll go to Sarah. Any comments on operational priorities given
Sure.
the regulations, but also the pandemic?
Sure. So there's actually a couple of things I just want to make a quick nod to first, and that is making sure that everyone is aware, everyone who works with a rural health clinic is aware that the HRSA program to get reimbursed for Data 2000 waiver training payments, that window is open. And so, that's something to make sure if your organization has been involved in that Data 2000 waiver training, you have rural health clinics, providers that are eligible to receive reimbursement for that. I want to make sure that that's on everyone's radar. And also thinking about building off what Brock just said with CMS, CMMI, I want to make sure it's on everyone's radar that the chart model, the ACO track, the request for applications we anticipate is going to be coming out in about a year, in spring of 2022. So, make sure that you're thinking ahead to whether participation in that model might be something that is appropriate for your organization or something that you want to make sure that you are staying in touch on and that you're aware as different pre-application TA resources and webinars and things like that are available. I also think, again, not to be sort of a broken record on RRPD and residency programs, but again, thinking about the connection between changes in the Consolidated Appropriations Act and that are being implemented in the IPPS rules, to make sure that you're thinking about whether or not your facility might benefit from some of those changes. For example, there were some changes that were made to rural training track requirements. There was information for critical access hospitals that got caught in that weird space where their PRA was set to 0, sort of artificially, being able to go back to CMS and reset the clock on that a little bit. So make sure that if you think that getting a rural residency program up and running might be a good fit for your facility, or participating as a rural provider in a RTT program might be a good fit for your facility. Make sure that you are tracking those changes on the policy side along with the grant funding that we anticipate will be available in fiscal year 22. Because, one of the things we know is that workforce, of course, was a perennial issue for rural that was only made worse during the pandemic and the public health emergency. And one of the tools that's available to help address that is making sure that more folks get access and exposure to rural during their training, because the research has shown that increases the likelihood that they are going to want to go back and practice in our rural communities. Of course, I don't want to go through all the telehealth pieces again. I know everyone has heard lots about telehealth, but again, I think thinking about for your community, for your facilities, for your stakeholders, what are the telehealth waivers that have been an improvement for your community and for your facilities, and thinking about how to best express that continuing those waivers would be good, or, to be neutral, good or not good for your facilities. I think those are important things to be thinking about as well from the operational side.
Great. Thank you, Sarah. And John, do you have additional items?
Yeah, thanks very much, Sally. When we look at the question and we look at the issue in terms of value-based alternatives, we still have one foot on the dock and one foot in the boat with respect to value-based alternatives. And we need to prepare for these alternatives going forward. And as Sarah's pointed out, CHART will be an example of this. So we all, I think, need to watch that demonstration, both transformation track and the ACO track, very carefully to see how that rolls out and how that will influence value-based payment alternatives going forward in rural areas. Sarah also referenced workforce pressures, and I would echo that. We continue they're going to continue to build. And so we need to find ways to allow clinicians to practice at the top of their license, to integrate primary care with behavioral health care and maternal health care, and then to supplement the clinical team with community health workers. And then we're also going to be looking at new models of delivery, which are going to continue to emerge. A hospital at home is an example we haven't talked about, and one that does have promise for rural communities in a manner of being able to make access to care easier for those who are able to be treated at home for an acute care illness. And critical access hospitals are going to have to consider the best alternative to assure a medical presence in their community. And I would say, lastly, we haven't gotten past the supply chain issues that were plaguing us, particularly early on under the COVID-19 pandemic and the national public health emergency. So there's still work to be done with supply chain.
Thank you, John, for noting that additional issues. Okay, next up, let's turn to what recommendations you all have for Flex program leaders and their state partners who are in our reverse site visit today to create opportunities for critical access hospitals so they can participate in new value-based care and population health models. And I'll go to John first on this one.
Sure. With respect to Flex program leaders and things that you can do, as we're looking forward to the future, the emphasis is on improving population health. And the most important tool in the shed is the electronic health record. So the ability to gather and warehouse data to understand high complexity, high frequency users is key to our success with respect to improving population health. And then health data sharing overall, it's gained prominence in terms of its importance. It's an innovative trend because of its potential to support healthcare workers, data acquisitions, and then patient records and interoperability. So that, I think, would be an area of emphasis as you move forward as well.
Okay. Thanks, John. And Brock, how about from your perspective?
Yeah, I think that leading off of what John just said, I think that as a participant in the Flex program in Mississippi, when I was a hospital CEO there, I think the biggest value that I received as a user of the Flex program was the collaboration and the networking and being able to use the power of that to lead towards change. And I think what I see that we need a lot more of is learning from each other. And I think that fostering those collaborations is important. Unfortunately, during the pandemic, the act or the ritual of getting together has been really dissolved completely, and we've not been able to do that as much. We've picked up on the tools of Zoom and other modalities that have been really important, I think, to bring people together. So I think that collaboration, networking, being a catalyst for the change that we want to see is really an important feature.
Okay, thank you, Brock. Okay, well, go to a question here in the chat, and then on rural health clinics. And this was from a comment you made, Brock, about provider-based rural health clinics being part of the advocacy efforts. And the question is, why are independent RHCs not included in the efforts to improve provider payments? And the understanding is they already have lower encounter rates in provider-based clinics.
Oh, good, really good question. And that was my apologies for a truncated discussion on the rural health clinic program as part of the Consolidated Appropriations Act. But what that did, what the CAA did, was to essentially provide for an escalation of the all-inclusive rate, or the AIR, for the freestanding, starting April 1st of this year to $100, going up to 2025 to $190. So freestanding rural health clinics were really improved considerably in terms of their reimbursement as part of the CAA. The pay for and we're in a budget neutral world within Washington, but the pay for was that they imposed an upper payment limit for existing rural health clinics that are grandfathered using the Medicare Economic Index for each year going forward. That could put a severe limitation on the increase in on the ability to expand care and to keep up with the workforce issues, because workforce is not getting any cheaper, and that's going to be really problematic to be limited to that Medicare Economic Index. The other side of that is that a new rural health clinic, even if it's provider-based, owned by a hospital, after December 31st of last year, will come in using the rural health clinic freestanding rates, essentially that $100 to that $190 level. So this could actually stifle the development of new rural health clinics to be able to provide outlets for primary care. All of the innovation that we're talking about here and that John and Sarah have discussed, those are going to possibly be limited as a result of that. So that's the concern. So our legislative agenda is to basically remove the limitation for provider-based, both at the Medicare Economic Index and to allow new rural health clinics to enter into the program without being constrained by the rural health clinic freestanding rate. So hope that helped explain that, Sally. I can't hear you, Sally.
What are the opportunities and possible programs to reduce disparities and improve health equity in rural communities? And we'll start with Sarah on this one.
Sure, thanks. So this is such an important topic, and I think, I'm delighted that there has been increased focus on this. One of the things that we are seeing from our office is that the biggest tool that we have from the Federal Office of Rural Health Policy side is having data to best understand what rural communities that we are working with actually look like, and use that data to make sure that we are informing our programmatic work, and to make sure that we are using that data to inform our policy work and how we are communicating with our colleagues across HHS. Because without that data and without that information, we can't make a argument that isn't based in anecdote. We have to be able to make the argument based in painting the picture of what rural America actually looks like, not the image that folks have in their heads, which is in many cases outdated and inaccurate. And so we are really working with our colleagues across HHS to make sure that we are getting access to data, that data is being collected, that research is being done that includes those cuts, to make sure that folks are able to use research to tell the story, that folks are able to use data that's being collected across the country at the county level or at the zip code level to talk about what's happening in their communities and to describe the communities that they are serving and working and living in. And again, for us to be able to make sure that we are including that lens, not as a separate piece of what we do, but that as an integrated aspect of everything that we're doing. And again, getting that information directly from rural communities to help inform our work for policies and programs that are not working for communities, particularly for communities of color and for other traditionally marginalized populations, is so important in making sure that we're able to do our work as the voice for rural across HHS.
Thank you, Sarah. And John.
Yeah, thanks very much, Sally. And I love Sarah's answer, because data is the window to understanding and knowledge in terms of making change. There are a lot of opportunities to reduce disparities, but I'm going to say let's start with ourselves, and let's make sure our leadership reflects the communities that we serve. You know, as hospital leaders, we have to commit to increasing diversity and inclusion in the boardroom, because more diverse boards make better decisions that lead to better care for patients and the communities. So having a diverse board also promotes authentic conversations among the members from varied backgrounds who have lived experiences which facilitate better understanding and appreciation of those differences. And we've got tools that are on our website that are important to that, but I think we really need to take this to heart and make starting with ourselves and making sure that the leadership reflects the communities we serve.
Thank you, John. Very well stated. And Brock.
Well, I'll add to those excellent comments from my colleagues, Sarah and John, and just say that I think incentives matter. If you've heard me speak before, you'll know that I really believe that as a provider in healthcare, we provide services around the models of how we're paid. And I think that we need to look at innovations around payment structures that incentivize not only the look that was mentioned already at the national level, but how do we turn data through a community health needs assessment, through various techniques at the local level to make sure that needs are being identified, they're being analyzed, prioritized, and then finally acted upon. And I think that action part is really critical. And I think flex programs can be extremely helpful in moving providers through that process. And I would say that facilitated needs assessments with help in the analysis can be really powerful as well, because then you get that objective third party to come in and help you see things that you don't see. I know as a hospital administrator, I was shocked when we did an inventory of health services in our community, and I found that we had far more health services being provided in my 2 counties than I ever imagined. So these are the kinds of things you learn through this process, and I think it's really helpful to use that power in this decision making.
Thank you, Brock. And finally, to wrap up from our panelists, if we could hear from each of you just briefly, since our theme is rural resilience for rural communities, or for healthier communities, what resources do rural communities need to inspire rural resilience? And I'll start with John because he's smiling here.
Yeah, I don't know what more resources we could provide to the folks who have inspired us. Though, those of us who are sitting here and trying to assist them as they treat and care for people under a national public health emergency. And the resilience and the actions that they've taken have been inspirational to those of us that represent and advocate on their behalf. And we'll continue to do so as best as we can.
Okay. Thank you, John. And Brock?
Well, thanks, Sally. I know we have a very short amount of time left in this session, but I do want to stress that resilience is that point at which you have the capacity to return to the state that you were in before. And that capacity is really important. And I think a good leader can actually understand where their organization is and intuit the needs that they have in order to restore themselves elastically back to that state. And I look at it as a rubber band, and you can stretch that rubber band, but you don't want it to snap. And I think leaders are really involved in that process. To John's point too, it is really impressive to see the leadership that's not only in rural America, but all over the United States in terms of dealing with this pandemic. So resilience is being seen every day, and I really applaud those efforts.
Thank you, Brock. And Sarah, any last comment on resources to inspire rural resilience?
Sure. So I agree with everything that Brock and John have said, and a little bit self-serving, which is not a great place to be in. But I would say that, one thing that's helpful for strengthening resilience is knowing that there is a support network and a place where you can voice our concern. And we, the Federal Office of Rural Health Policy, are available to be that voice. We want to be that voice for rural with our HHS colleagues. So please use us in that way as a resource to make sure that we are able to effectively lift up the concerns that you have and also your successes, because I think those are so important to highlight as well. Sometimes we really focus on things that aren't working in rural, but there's so many things where rural communities excel and exceed expectations and provide, wonderful high quality healthcare services. And we need to make sure that we're being the voice for that across HHS as well. And building on that, flex programs are key partners in this work as well. And we just appreciate your role as connectors for linking communities within your state and also sharing information back with us.
Great. Thank you, Sarah. And thank you, Brock and John, for the lively conversation and all the information shared on policy and regulations for critical access hospitals and flex programs. So now we will have a 30-minute break. There are some optional networking sessions, and those conversations are listed in the hub. We have policy and regulation. If you want to talk more about today's topics that you just heard, the operational financial improvement activities involving rural EMS in local community health, resiliency skills, and finally supporting CA leaders. So again, those links are in the attendee hub that you can get to those networking rooms. Then the next breakout sessions begin at 1:45, and those links will be found in the live session hub. So have a great break or conversations. And again, thank you to our panelists.